Hi, my name is Evelyn Brevel. My presentation today is about substance abuse in pregnancy, and I will be focusing on tobacco. Tobacco is a plant originated from South America. It is used in two forms, smoked tobacco and smokeless tobacco. Smoked tobacco are used in form of cigarettes, cigars, and water pipe. Smoked tobacco products contain more than 7,000 chemicals, and 70 of them are known to cause cancer. The harshest and most addictive chemical in tobacco is nicotine. The smokeless tobacco form, the leaves can be chewed, can be inhaled, or can be applied and held between the gums and the lips. CDC 2016 U.S. statistic data on delivered women who self-reported smoking during the pregnancy shows 1 in 14 women who delivered smoked cigarettes during pregnancy. 7.2% of them smoked cigarettes during pregnancy. And Florida statistics for the same period shows between 5 and 7.1 women who delivered smoked cigarettes during pregnancy. The prevalence by age group, level of education, and ethnicity will be displayed in the next two slides. Let's look at the chart on the right side of the screen. It shows clearly that the highest prevalence of pregnant women who self-reported smoking during pregnancy is among those aged 20 to 24 years old, which is about 10.7%, followed by the women aged 50 to 19, 8.5, 25 to 29, 8.2, 30 to 35 years old, 5.2, 35 to 39, 4.4, 40 to 44, 3.6, under 15, 2.5, and 45 and over and older, 2. In terms of prevalence by ethnicity, non-Hispanic American Indian and Alaska Native account for 16.7%, followed by white women, 10.5%, black, 6%, Hawaiian or Pacific Islander, 4.5%, Hispanic, 1.8%, and non-Hispanic Asian, 0.6%. On the educational level, women with high school education or a GED account for 12.2%, less than a high school education, 11.7%, some college or associate's degree, 7.9%, and a bachelor degree or higher account for 1% or less. Smoking tobacco in any forms can cause major health issues such as heart disease, stroke, cancer, lung disease, diabetes, chronic obstructive pulmonary disease, COPD, so on and so forth. Smoking tobacco can also cause some behavioral issues. Studies show that tobacco use and dependence may simulate a manic picture. It can coexist with anxiety. It can coexist with depressions as well. Nicotine, the addictive chemical found in tobacco, can induce euphoria. It is highly addictive and create dependence. The mortality rate among the general populations shows that cigarette smoking accounts for 480,000 deaths per year in the United States. Secondhand smoke exposure accounts for 30,000 heart disease deaths, 40,000 deaths among adults, and 400 deaths in infants each year. I will not be able to establish a direct cause and effect of cigarette smoking and pregnancy-related death. However, the collection of data from 2011 to 2015 shows that heart disease and stroke is the leading cause of pregnancy-related death, followed by bleeding and infection. 700 women die each year from complications of pregnancy, and heart disease accounts for 34%, which is about 1 in 3 deaths. 31% of deaths occur during pregnancy, 36% at delivery or 1 week after, and 33% 1 week to a year postpartum. Maternal, fetal, and perinatal risk associated with smoking during pregnancy are listed above. Maternal risk include but not limited to preterm labor and delivery, spontaneous pregnancy loss, ectopic pregnancy, placental abruption, preterm premature rupture of membrane (PPROM), placental previa, preeclampsia, and stillbirth. Smoking during pregnancy increases the risk of health problems for developing babies as well, which include impaired fetal oxygenation, fetal growth restriction, low birth weight, cleft lip, damage to the fetus lungs and brain, musculoskeletal defects, which is clubfoot, and craniosynostosis. In addition to maternal and fetal risk, perinatal risk associated with smoking during pregnancy are low birth weight, cleft lip, reduced maternal milk, musculoskeletal defects, gastrointestinal defects such as gastroschisis and hernia, respiratory infections, ear infections, asthma attack, and sudden infant death syndrome, SIDS. A former smoker complaints may mimic the signs of withdrawal. The patient stated she is a former smoker. She quit smoking in the beginning of pregnancy, and now she is complaining of fatigue, headache, anxiety, irritability, insomnia, and difficulty concentrating. The patient's general appearance may reveal grayish skin, premature wrinkle, halitosis, tau-stained feet, darkening of the gums, gray hair, bloodshot appearance in the eyes, and discolorations of the fingernails. On physical exam, the heart rate may be accelerated, increased blood pressure, a BMI less than 18.5, and accelerated speech. Possible differential diagnoses that can be implied are anemia, gestational hypertension or preeclampsia depending on the gestational age, withdrawal syndrome, depression, anxiety, and dehydration. For these particular patients, a high risk prenatal care should be developed and implemented at each encounter and throughout the pregnancy, along with the 2 A's in our model approach. The 2 A's in our model approach consist of asking the patients about tobacco use at each encounter, advise her about quitting, and refer her when she shows signs of readiness. Prenatal care, the first trimester consists of fundal height, fundal heart tone, height and weight, blood pressure, urine dipstick on every visit, PHQ-9 questionnaire, first trimester lab, CBC, RPR, tap and screen, antibody screen, hepatitis B and C, rubella, touch lab, HIV, GC, UA, culture and tox, dating ultrasound on initial visit, integrated screen blood test at 10 weeks, and ETC between 11 and 13 weeks, carrier screening as appropriate. On the second trimester, Still, the 2 A's and R model approach will be applied. Ask the patient about tobacco use, advise her about quitting, and refer her when she shows signs of readiness. Prenatal care, fundal height, fundal heart tone, height and weight, blood pressure, urine, dipstick on every visit, integrated skin, blood joint number 2 between 15 and 22 weeks, preeclampsia blood work if proteinuria, 24-hour urine protein and creatinine if proteinuria, pharmacology treatment for blood pressure if blood pressure is greater than 140/90 plus proteinuria, fetal movement awareness, fetal anatomy ultrasound between 18 and 22 weeks, glucose challenge test between 24 and 28 weeks, and antibody titer if RH is negative. On the third trimester, 2 A's and R model still in applications. Ask the patient again about her tobacco use at each encounter, advise her about quitting, and refer her if necessary. Third trimester prenatal care, fundal height, fundal heart tone, height and weight, blood pressure, urine dipstick on every visit. Third trimester lab repeated CBC, RPR, hepatitis B and C, HIV, GC, and chlamydia. Group B strep between 35 and 37 weeks. Fetal movement awareness, fetal movement count, close fetal surveillance by serial NST and BPP if positive maternal and fetal risk, if it's less than, the patient is less than 37 weeks, and perinatology consult with serial OB ultrasound for growth if positive and maternal risk present, if less than 37 weeks, and plan to deliver if positive maternal fetal risk still present if the patient is 37 weeks or greater. Health promotion. The patient will be counseled about prenatal care, adherence, and compliance, fetal movements awareness, fetal count, expecting 10 counts in 1 to 2 hours, behavioral counseling, smoking cessation, provide the patient with phone of tobacco helpline resources, and with some handout educational strategies to quit smoking, which is develop a quick plan to identify smoking triggers and develop coping strategies to quit smoking. And I believe I have covered the major points about tobacco abuse in pregnancy. And here is the reference page. You can go over it. And thank you for listening.